Okay, this lecture is really the place to begin as we systematically go through clinical neurology. So we're going to start with muscle disease, and we'll work our way up to the cortex of the brain. The reason I think this approach works the best is we can slowly incorporate more neuroanatomy, more pathways as we continue. All right, so we'll probably spend the least amount of time on muscle disease, and more time, obviously, as we get further up into common conditions like headache, dementia, and stroke. But there are some important things you need to know about muscle disease. So we're going to start here today, and then next time you want to go over the neuromuscular junction, and then we'll work our way up to the spinal cord and so on. All right, so let's go through some of the common muscle diseases that you might encounter. In terms of just a very big picture, we always want to remember that a muscle disease generally presents with proximal muscle weakness. All right, and since we're not involving the nerves, this is not a peripheral neuropathy or a central nervous system process for the most part. Patients don't have sensory findings. They don't have numbness and tingling. Their sensory exam is going to be normal. So the presentation is generally weakness, and generally, but not always, in more proximal muscles. And then we'll see as we go through some of the unique myopathies that some have some special, interesting additional features. All right, so as a big category of muscle disease, of course, we have the muscular dystrophies. And we'll go through three common muscular dystrophies: Duchenne's, Beckers, and facioscapulohumeral dystrophy. In terms of a big category, muscular dystrophies are hereditary and generally progressive, not treatable, although there are some important interventions for these patients. The other category we're going to go through in this lecture will be inflammatory myopathies. We'll talk about three: polymyositis, dermatomyositis, and inclusion body myositis. Okay, just so that you know the other categories of muscle diseases, which we won't talk about, one of them is congenital myopathies. And there are well over 50 types of congenital myopathies, which we just won't go into because it's very uncommon. But again, these are hereditary, generally present at birth, and these can be slowly progressive or not progressive at all. There's a fascinating category of myopathies called metabolic myopathies. And here, because the metabolic machinery in the muscle is affected, generally these patients present with exertional weakness and pain, and sometimes myoglobinuria related to exertion. So after a long run, something like that, patients may have muscle pain, and they may have a change in urine color, sometimes known as a Coca-Cola urine. There are certain types of metabolic myopathies that can present with a progressive muscle weakness. We won't go into those, but just so that you know, when we talk about something like polymyositis, to be aware that there are some things that can mimic polymyositis, and some of those are metabolic myopathies. Okay, another category we won't go into, but I want you to have a big picture sense for this type of muscle disease, and that is mitochondrial myopathies. Mitochondrial myopathy is not common, but it has unique things that the patient also presents with besides proximal muscle weakness that would be a clue. And usually the biggest obvious thing is a progressive eye movement problem, usually with ptosis. This can eventually be very severe. These patients frequently will have a retinitis pigmentosa, and they may also have a form of epilepsy known as myoclonic epilepsy. Okay, so again, in that patient presenting with progressive proximal weakness, you're also finding an eye problem, perhaps epilepsy, would suggest you're dealing with something in that family. All right, so a couple of other conditions I'll just mention in passing. There are a number of endocrine myopathies. Okay, so we want to be aware of that. And again, in our differential perhaps of polymyositis, we might want to rule out some of these endocrine-related myopathies. There are interesting myopathies related to electrolyte disturbance, which again we won't talk about. These are fascinating. One condition known as hypokalemic periodic paralysis, where patients usually after a high carbohydrate meal the night before wake up paralyzed. Okay, and you find low potassium. okay, but not very common conditions. And then at the end of this lecture, we'll briefly mention a couple of toxic myopathies. You should be aware that there are a number of medications that can affect the muscle. Probably the most important for you to know is that the statin medications, the lipid-lowering medications can cause a myopathy. Long-term use of steroids can cause a myopathy. And a common medication used in the treatment of HIV, known as zidovudine, or AZT, can cause a myopathy. All right, so let's go back now. Let's start with the muscular dystrophies. And again, I'd like you to know about three: Duchenne's, Beckers, and FSH dystrophy. And then we'll talk about myotonic dystrophy. So actually four we're going to go over all together. All right, so muscular dystrophies are hereditary. Okay, that's one feature. And the other is they're steadily progressive over time, slowly progressive weakness. And Duchenne's is the most common of these in childhood. And because Duchenne's is an X-linked recessive disorder, this is something that is seen in young boys for the most part. Women are asymptomatic carriers, again, for the most part. Okay, so this is a very sad condition where boys, usually not diagnosed at birth, but around 12 or 18 months, begin to have motor decline. Okay, so the genetics of this condition, the problem is on the short arm of the X chromosome, XP21. This is the largest gene yet identified in humans, and the protein product is called dystrophin. And as you can see here on the picture, the protein here, dystrophin, links actin with the sarcolemma. Okay, and so it's thought that in terms of the mechanism of Duchenne's, that when we lose the dystrophin, that especially with exertion, there's breakdown of the muscle membrane and leads to muscle destruction. Okay, so Duchenne's, there are about 30 per 100,000 or about 1 in 3,500 male births. And important here that about 1 in 3 cases of Duchenne's represents a new mutation. Okay, because patients with Duchenne's don't live long enough to reproduce for the most part, if there weren't these ongoing new mutations, the disease would slowly go away. So we need the ongoing mutations for this condition to persist. So the presentation is a normal boy at birth. Okay, generally, there's no suspicion of any abnormality. But then by about 18 months, certainly by 2 years, parents are concerned because the child doesn't seem to be walking normally. He's not keeping up with other kids. Normal walking is around 12 months of age. Patients with Duchenne's generally don't walk until after 18 months. And then family notices they just don't get around normally. They have a hard time, for example, crawling up or walking up stairs. They seem to walk funny. So these would be the typical complaints that would lead parents to bring their child into a pediatrician. Some of the earliest muscles that are involved in Duchenne's are the neck flexor muscles. So that's why when we're seeing these children, we'll have them lie down on the examination table with their head leaning back off the edge of the bed. And they have great difficulty going to a sitting position because they can't flex the neck adequately. Okay, so neck flexors are involved early, and the proximal muscles, arms and legs. Okay, and so if you have severe proximal muscle weakness in the legs, again, anything that would involve climbing stairs, getting up off the floor, it's going to be very difficult. So something you should know about, it's known as the Gower sign. Okay, no S at the end, just the Gower sign. And you can see a picture here of how these children rise from the floor. Okay, and because the proximal muscles are weak and the plantar flexors are strong, okay, notice how this boy is standing up on his tiptoes and then uses his arms basically to walk up the legs. Okay, the Gower sign is not something that is specific for Duchenne's muscular dystrophy. It can be seen in a variety of conditions, okay, but it's a classic. You will see this in every child that presents with Duchenne's. Okay, so again, preserved muscles in Duchenne's are the plantar flexors, okay, the gastrocnemius muscles, in other words, and foot inversion tends to be preserved. Okay, so even in these cases where the child progresses to the point where they're in a wheelchair and really severely disabled, very weak, you still will generally detect that those plantar flexors have good strength. Okay, just in terms of observation of the muscles, very important, you'd want to look at muscles for hypertrophy. And early on, this may be a true hypertrophy in the calves, but over time gets replaced by fat, and we call it a pseudo-hypertrophy. All right, so calf hypertrophy would be a classic feature, clinical feature of Duchenne's. There may be other muscles that hypertrophy, for example, the deltoids sometimes may have a pseudo-hypertrophy, but calves would be the classic example. And you can see a picture here of a child with calf hypertrophy. All right, so there are progressive problems with walking generally, and typically by about the age of 10, these boys need long leg braces in order to ambulate or to stand. On average, and again this is a variation, but on average, boys are wheelchair dependent by the age of 12, and death usually occurs around the age of 20, typically due to respiratory failure. So the complications of Duchenne's are respiratory, okay, and this is for a combination of reasons, but often because they have kyphoscoliosis. Just from an orthopedic point of view, there's some degree of hypoventilation. And then there also is some muscular involvement of the diaphragm and intercostal muscles as well. Cardiac is another consideration. 90% of patients with Duchenne's have abnormal EKGs, but the majority of these are not symptomatic. Okay, so we'll generally check an EEG, but most of these patients are not passing out and having symptoms from that. Now, a very unique or unusual feature is that the standard deviation in terms of IQ is about 1 standard deviation below the mean. It's not known. Why should this genetic abnormality that affects muscle lead to a lower IQ? Okay, but it's something that has been observed. So you're suspecting Duchenne's. How do you make a diagnosis? Remember, anytime there's an active breakdown in muscle, we always want to check a creatine kinase, muscle enzyme. And this is probably the highest elevation that we see in terms of any muscle disease is Duchenne's. So you do a creatine kinase, even if you were to do this at birth before the boy has symptoms, dramatic elevation, 10, 20 times normal. All right, so a normal CK would certainly rule out Duchenne's muscular dystrophy. You could do an EMG, although typically not necessary. We'll come later to EMG features of muscle disease. Muscle biopsies were commonly done until the last few years when we have a blood test for this. But when you do a muscle biopsy, you can stain for dystrophin. And here's a picture of a staining for dystrophin, which is absent in Duchenne's muscular dystrophy. Okay, we also want to look at the genetic picture. Does this fit for an X-linked recessive condition? And here you see two parents, and you can see that the mother here has an affected X chromosome. And so there are 4 children in this case, and you can see the two on the right of the screen received the healthy X chromosome for the mother, and so the boy in this case is asymptomatic. The girl is not a carrier. Okay, and then the two on the left of the screen, the girl received the abnormal X chromosome, so she's a carrier. Again, not likely to exhibit any symptoms. And the boy then gets the involved X chromosome from mom, the Y from dad. So it's X-linked recessive. So this boy will have all of the clinical features of Duchenne's muscular dystrophy. Okay, so again, because death generally occurs by the age of 20, sometimes earlier, most of these children do not reproduce, and so there are new mutations that perpetuate the condition. Okay, so if a child is diagnosed with Duchenne's, oftentimes parents want to know, well, what's the chance of our next child having Duchenne's? Okay, so a single child with Duchenne's and no other family history of Duchenne's, this could just be a new mutation. Okay, so we could only really positively say the woman's an obligate carrier, in other words, a 100% carrier, if there are 2 sons or if there's a family history, okay, not just in one isolated case. So the nice thing about Duchenne's now is we can just do a blood test which detects well over 90% of patients that have Duchenne's. So DNA analysis reveals a deletion typically or duplication at XP21 in most all patients. Okay, so how do you treat Duchenne's? Well, there's no cure. What is controversial is use of steroids. Controversial because, as we'll discuss as we go through these lectures, there are many, many side effects of steroids. What some child neurologists who specialize in this will do is use steroids around the age of 5 until the child is wheelchair dependent, because it can lead to some improvement of muscle strength. It can benefit these boys, but again, being aware of the side effects. Okay, and so it's not an easy decision. Most of these muscular dystrophy clinics are patients are seen by a child neurologist and an orthopedic doctor, because so many of the things that can be done are orthopedic in nature. The braces, very important, for example, that these children have a very good wheelchair, that they're not bent over, which will accentuate the kyphoscoliosis. Sometimes spinal stabilization surgery. And most of these cases, of course, patients and families are not interested in ventilators. Okay, so that's Duchenne's. Beckers, just think of Beckers as the same as Duchenne's, but it manifests later, has a much slower course. So it's a defect of the exact same gene, 10 times less frequent than Duchenne's. So we see about 3 cases per 100,000 compared to 30 per 100,000 for Duchenne's. And in this case, new mutations account for only about 10%. Okay, but the pattern of weakness is identical. Proximal muscle weakness, calf hypertrophy, preserved plantar flexion. Okay, so it's the same general picture as Duchenne's. These boys may not develop any symptoms until later, may not even be diagnosed until 10 to 15, okay, or felt that there's something wrong, but frequently down to the age of 5, there will be some obvious motor abnormality. Okay, but contrast again with Duchenne's. Most patients die by the age of 20. With Beckers, 90% of patients are still alive at the age of 20, and most survive into the 4th and 5th decade. Same complication, though, death is usually due to respiratory failure. So here are a few pictures of patients who have Beckers muscular dystrophy. You can again appreciate the calf hypertrophy. Diagnosis, very similar. You still have your elevated creatine kinase because this is an active muscle breakdown. And again, your genetics test will be virtually 100%, or certainly well over 90%. Okay, what's important in Beckers is genetic counseling. Okay, so these boys grow up, have families, and need to be aware of how this condition is passed on, as I went through previously. Okay, now, so Beckers and Duchenne's, and then the most common adult-onset muscular dystrophy, which is myotonic dystrophy. And myotonic dystrophy is a very unusual type of muscular dystrophy because so many of the manifestations are not muscular. There are other systems that are involved. Okay, so the incidence here is about 13 per 100,000. And the variability of presentation within families. I've seen some patients severely affected in their 20s and 30s with myotonic dystrophy, and then in another case, a man diagnosed in his 70s with myotonic dystrophy. Okay, so it's extremely variable even within one family. Presentation is generally in the 2nd and 3rd decade with symptoms, which we'll go through. There is a congenital form of myotonic dystrophy with onset in neonatal period, which I won't go into. Okay, so clinical presentation, frequently facial weakness is the most obvious manifestation. And when you've seen just 1 or 2 patients with myotonic dystrophy, typically you'll remember the face and how it looks, and because it's so stereotypic. So there's frequently wasting of the temporalis muscle. And so that has a unique feature, as you can see on the pictures. There's typically ptosis, droopy eyelids, often weakness of facial muscles. So when patients try to smile, it's kind of a glum, expressionless smile. The tongue and palate and pharyngeal muscles are affected, and so when they talk, they typically have somewhat of a nasal voice as well. And then they have weakness of the sternocleidomastoid muscles. All right, so again, there's a few pictures of patients with myotonic dystrophy. And in terms of the weakness, here is one example of a muscle disease that doesn't fit the typical pattern. Remember, we just said muscle disease, usually proximal muscle weakness. Myotonic dystrophy typically has distal weakness. So patients may present with a foot drop, for example, or weakness of the hands, so that patients have difficulty opening jars. So it's distal more than proximal. And also the diaphragm and the respiratory muscles tend to be weak. So there can be some early respiratory involvement. Now, what is myotonia? Myotonia is an inability to relax a muscle once it's contracted. All right, and so patients frequently may not even be aware of this, although some patients are. And so one patient I saw was gripping onto a subway in New York and tried to get out of the subway, and his hand wouldn't let go of the pole that he was holding on to. Okay, that was myotonia. Couldn't relax the muscle. And so there are different types of myotonia. When we check this clinically, you might just have a patient squeeze your hand tightly and then try to let go. They have a hard time doing that. You might have the patient close their eyes tightly and then see if they can open them up quickly. Someone with myotonic dystrophy will have a difficult time doing that. We'll also check percussion myotonia. For example, if you tap on the thenar eminence of the hand, that induces myotonia, and you might see the thumb go up like this, and it may hold that position for a few seconds and then relax back down. Okay, or you can tap on the tongue, and you can see the picture here, and tapping on the tongue leads to what's sometimes called the napkin ring sign, where the center of the tongue constricts for a period of time. Okay, and again, that is myotonia. Okay, so that's the muscular manifestation of myotonic dystrophy. And now just appreciate all of the other things. This is not just a muscle disease. Okay, patients have cardiac conduction disturbances, a whole variety of arrhythmias, all the way up to severe heart block. This is probably the most important one for you to be aware of, because if you're a primary doctor and you're seeing a patient with myotonic dystrophy and they're telling you, I keep getting dizzy, or I passed out a week or two ago, I want to take that very seriously, because these patients, if you put a pacemaker in, they do fine. Okay? You don't want to miss a serious arrhythmia in a patient with myotonic dystrophy. Other non-muscular manifestations, mental retardation is especially in the congenital form. Respiratory insufficiency, I mentioned the muscle involvement, but interestingly, patients with myotonic dystrophy also frequently have a central sleep apnea, central hypoventilation that contributes to the respiratory problem. Cataracts are a very typical feature. So again, if you're taking a family history, maybe they haven't been diagnosed with myotonic dystrophy. But if you're getting these other things, oh yeah, everyone in my family's had cataracts, that might be important. Also, frontal balding contributes to the typical facial appearance. And so again, a family history where everyone has early frontal balding might be a clue. And then there are areas of endocrine dysfunction, insulin resistance, testicular atrophy with lowered testosterone levels can all be a part of myotonic dystrophy. So again, we'll just scroll through a few more pictures here so you can appreciate the typical facial appearance of someone with myotonic dystrophy. So how do you make a diagnosis? Well, again, we might check a muscle enzyme, creatine kinase. Okay, but this brings up an important point. This muscle enzyme is not elevated in a muscle disease where there isn't active muscle breakdown. Okay, so typically the CK is normal in myotonic dystrophy, even though this is a muscle disease. Normal CK does not rule out a muscle disease. We'll frequently do an EMG in these patients, and when you put a needle in the muscle of a patient with myotonic dystrophy, you get what are known as myotonic discharges. And this sounds just like, if you've ever seen some of those old World War II movies of the dive-bombing planes. Sounds just like that. Very obvious to diagnose in the EMG lab. You might want to look for cataracts in your patient with myotonic dystrophy, do an EKG, look for any cardiac conduction abnormalities, and then genetics tests. So usually it's pretty obvious. Typical facial appearance, family history, okay, and this is autosomal dominant, so there are usually lots of family members that have had similar problems. And the genetics testing is looking for a trinucleotide repeat. This is the first of several trinucleotide repeat conditions that you should know about here in neurology. And myotonic dystrophy is a CTG trinucleotide repeat on chromosome 19. Okay, and there's a great blood test for this, and you can confirm diagnosis. Okay, one other thing to say about the genetics of myotonic dystrophy. Myotonic dystrophy, like Huntington's disease, we'll talk about later, has something that's known as anticipation, where basically there's an increase in severity of the disease in excessive generations, okay, and this is especially with maternally transmitted cases. Okay, so when someone with myotonic dystrophy gets it from their mom, they're more likely to have an earlier onset and more severe case of myotonic dystrophy. Okay, how do you treat myotonic dystrophy? Well, again, we don't have a cure for this, but some of the most important things would be, number one, don't miss a cardiac arrhythmia. Put in a pacemaker. If you've diagnosed a cardiac arrhythmia, if your patient with myotonic dystrophy is passing out. Other things that can be helpful, again, because it's mainly distal weakness. If your patient with myotonic dystrophy has a foot drop, well, send them to physical therapy so they can do an AFO, or an ankle foot orthosis, which slips into the shoe, prevents the foot from dropping down. Okay, patients will be very happy if you take care of that. In terms of the myotonia, most patients are not bothered by this enough to actually go on medications. But there are a variety of medications that can help for the myotonia, mainly seizure medications like Dilantin, Tegretol, or carbamazepine. Mexiletine is something else that can help with the myotonia. Be aware of complications like cataracts. If your patient is having visual problems, refer the patient to ophthalmology. And then more complex is the respiratory problem. If they really have a central hypoventilation, then sometimes we'll need to use a variety of stimulant medications to help the patient stay awake.